Now this is important. The informed consent agreement is very important. You can't start a case unless they sign an informed consent agreement. In the informed consent agreement, you must tell them that, you know, when they wake up in the morning, their teeth may not touch, but you just have to you know, just go have a shower and have a shave if you're a man, and then have your breakfast. Your teeth will probably touch in 10 or 20 minutes. Sometimes they touch immediately. Sometimes the teeth will move a little bit long term. Most of the appliances I use are hard acrylic, and I find the teeth are not moving very much. But you've got to warn them that the teeth could move. Okay, so if the teeth could move, then you're gonna have to deal with that problem. But if you're saving someone's life, or you're preventing heart attacks, strokes, or diabetes, they shouldn't worry if their teeth move a little bit. But I haven't had a big problem with that. You also tell them that because you've got sleep apnea, and you do, you're mild sleep apnea, but you have it, we've got to get you back for another sleep study. So you've got to agree for another sleep study. And I should have had him sign that, but he signed it. He signed it. And you just have to talk about, you know, what sleep apnea is, what snoring is, and he has to come back for another sleep study. And you might end up with a few minor problems with the appliances, but it's minor. And they sign it and they agree. We're going to start. So there's the oral appliance. You saw that at the outset. And there's I call that the dorsal fin. And what happens is that part there hits that part there and can't go back. So again, the patient can't go back. Okay? And that's a great appliance. Now sometimes we'll put, if there's no undercuts on the lower or the upper, we'll put ball clasps. But if there's some nice undercuts, we're using dual laminates now, which are softer on the inside and harder on the outside. They won't last as long as the all acrylic, but they're very comfortable. So most of my patients now I'm going dual laminates, softer on the inside, harder on the outside, and no ball clasp. The problem with the ball clasp, if they get bent, they could open up a contact point and cause a problem. So I prefer the dual laminate, but only if there's some undercuts. So call your lab and get them to agree that if there's no undercuts, they put the ball clasp. If there's undercuts and they get good retention, they go for the dual laminate. And I like the fact it's open in the front, so the patient can definitely wear or get a cold at night and still breathe through their mouth. They're fine. And as I say, that's a very comfortable appliance. I like it because it's a two-piece appliance. They can open and close. You don't want to go for a one-piece appliance. You want a two-piece appliance. So I actually had to bribe him a little bit. I think I had to give him $100. I had to give him $100 to motivate him to go back for another sleep study, because I really wanted to make sure I fixed him. So the sleep study before the oral appliance and before the surgery, removing the tonsils and the uvula, was 49, severe, and now I got him back to 1.4. So he's now normal. He's 1.4. That's great. But it needed both. I needed the ENT to get out the tonsils and part of the uvula, and I needed the oral appliance to move his jaw forward, because I took him from 12 to 1.4 with the oral appliance. So I got him from mild to moderate, mild to normal. Got him from mild to normal. And remember, the #1 treatment option for mild to moderate is the oral appliance. But again, I wouldn't have put the oral appliance in without the ENT's help getting out the obstruction in the back of the throat. Now this is also very interesting. We have to think about oxygen desaturation. We have to think about the blood oxygen level going down and the carbon dioxide going up, because that's very bad for your health. And he was having, when we did our home sleep study on him, he came out 42, severe sleep apnea, but he had 177 events when his oxygen was desaturating, which is very, very bad. Okay, normal oxygen saturation is 96, but he went down to 85 sometimes, which is any below 90 is bad, but you really should stay at 95, 96. You're not supposed to go down to 90, you're not supposed to go down to 85. But what's really neat is as soon as I put in the oral appliance, he went to 1. AHI was 1.4 or something, right? And no no desaturation. The oxygen level stayed at the right level the whole time. Well, he's no apneic events. No apneic events, no oxygen desaturation. Okay? So when he's having all these apneic events, 42 times an hour or 49 times an hour, depending on the sleep study, he was having 177 events at night when his oxygen was going down below, which was dangerous for his health. So, kind of neat. I, as a dentist, missed these patients for many years. I didn't realize the importance of snoring and sleep apnea and how bad it was for someone's health, long-term health, and long-term survival. We didn't learn in school. If you have someone you know that snores, you might want to recommend that they go see their physician and get a referral for a sleep study. If they're diagnosed with mild and moderate cases, mild and moderate sleep apnea, then they can maybe refer to a dentist for an oral appliance. If they're severe, they should probably go back to the hospital or back, they call it a DME company, durable medical equipment. It's the same company that sells oxygen machines and everything for people that have emphysema and asthma, that need oxygen, full-time oxygen. They have to go back to one of those places and get fitted with a CPAP device. What are the chances of him wearing a CPAP device, do you think? What 18-year-old wants to wear a CPAP device? It'd be very difficult to get him into one of those. But I still, if he was severe, I would have still recommended that he go for that. But luckily, getting the tonsils out, putting the oral appliance in, we got him down to normal, HI of 1.4. So that's great. So, as I tell the dentists, I feel badly because I've been in practice many years. And many, many years I missed diagnosing these patients because I didn't know. But the very least you must do is diagnose them. You need to diagnose them, you need to get that TMJ health questionnaire form, and if they answer yes to snoring, you've got to give them the Epworth sleepiness scale. If they've got a high number with the Epworth sleepiness scale, then I recommend that you send them for a sleep study. And then you can decide either to treat the case or refer to a dentist in your area that treats these patients. But honestly, these are not difficult patients to treat. Your staff will do a lot of the work for you. They'll do a lot of the records and a lot of the education for you. And we recommend that the staff take a course at the same time as the dentist. So all my sleep courses that are live courses have a staff course going at the same time. My staff are the ones that educate the patients, convince the patients to go for treatment, convince the patient to come back for diagnostic records, and do most of the records. I mean, I insert the appliances and I adjust the appliances, but most of the records are done by the staff. Most of the time is spent with the staff. And so it's a very staff-oriented part of dentistry, which is kind of nice. Because you can be doing general dentistry over here, you have a hygienist over here doing deep scaling and curettage, have another hygienist over here doing sleep, or a dental assistant doing sleep. You know, so you can have income coming from different areas, and you can be providing a great health service for these patients. These patients need to be treated. And there's only a very small percentage, less than 1% of all the dentists in North America who are really geared to treating these patients. So I think it's something that all dentists should think seriously about.